you called this. So
So the reason why is because, you know, Jackie will call us over to make sure that we can redo the dressings and what supplies we normally would use. We came into a little situation where you helped us because we had a Coban pressure dressing and we haven't done that before, so we would like to get in service and see what little box or wherever she's gonna put it of items that we're gonna need as nurses for your wound care patients.
great. I think when we started speaking, the first thing that we talked about is, you know, where we're going to keep the supplies.
Right.
I think that your volume, Jackie, is high, and I don't know that a toolbox is
I know.
a tackle box is really going to a tackle box is really going to suffice more than a shift.
Right.
You know, or you may run out of what you need, and that you don't want that. I mean, when we put in a Foley catheter, we bring 2 to bedside. You know, so, and again, because you know, not that there's waste, but you know, the dressings have to be put on correctly.
Yeah.
So, you know, I think that what we were trying to see is, okay, what in the vascular lab upstairs, is there a cabin or a space that we can utilize supplies for, or I know way back, you know, 1937, when I was doing the wound care over in the hyperbaric chamber room. I don't know if you guys ever been over there. There's 4 hyperbaric chambers in the chamber room, and patients would have to come out of the chamber room and go into an exam room. But I had wound care patients coming in. So what that did is they were clashing, and it was blocking up the rooms, and it was blocking up the chambers, and it was an awful mess. So what we did was we said, okay, you know what, we're gonna bring a nurse into the chamber room so that we can do those dressings, kind of like the similar situation that you have here, you know, where one of your team is going to go upstairs and do a dressing, so that we can kind of a little bit more have a little bit more organization and cohesiveness with the patient flow. So what I did, because we didn't have that set up, so I kind of took an old crash cart and I stocked it with supplies for the nurse. So the nurse basically kind of wheeled it on over to the patient, and whatever the order said, the nurse, you know, kind of did it and had all the supplies, you know, ready at the hand. I don't know if that's something that's feasible or something that's, you know, something that you would want to do, or a cart per se, kind of like a wound care cart.
Yeah.
You know, your little tackle box kind of looks like you're going fishing. And, you know, years ago, I don't know, probably most of you, I know, Corey, you were here for this, you know, when the Department of Health came here. You know, having, you know, this type of wound care center here is unique. It's great because it's fantastic for the community, and but we also have a tremendous amount of supplies that the hospital population doesn't have. So when the doctors come on over and they order something that we would have at the wound care center, they may not necessarily have it here, and that became an issue with a surveyor at one time.
Okay.
So what we wanted to do is kind of make it uniform, and that's when we came up with the idea of tackle boxes, you know, on the units. So, so each unit supposedly has them. I know that we did it years ago, well before, you know, your time, Julissa, but with Donna, with Donna, and we came in and we did an in-service and had, you know, the different types of products. So that tackle box, it's probably in the back of somebody's pickup truck, you know, serving its true purpose as a tackle box
Nowhere
now.
to be found. Nowhere to be found.
So, but I think that, you know, I think Jackie's a little beyond the tackle box, because I think your nurses, you know, there's only so much you can fit in a tackle box, and there's a
Yeah.
lot of supplies, and I want to give you a little smorgasbord of everything that we use, so that you're not like, I don't have that.
Right.
So, you know, I don't want you know, when you're in front of the patient and you have the wound exposed, is not the time when you want to say, I don't have that. So you know, it's important for you, and only fair for you guys to be prepared for the patient that you have. So I think something a little bit more robust than a tackle box would be a little bit more suiting, you know, whatever you guys decide that it is. Now, I know that we spoke about what Jackie's ability, you know, Jackie is amazing and wonderful, and you know, she really, I don't know how she survives with 2 arms. And Melissa Gazzola is another one. She's just, you know, fabulous.
She's got a great team.
Yeah, I think that you guys have, like, you ever see Avatar?
Yep.
Like, sometimes I wish I had an Avatar tail because it was so useful. I believe that these girls have Avatar tails. But I know that there was some interest in, you know, Jackie's just like, I want to get it done, you know, let's, you know, what can I do? What is my scope? What is my limitations? And, I don't want to. I know that in the outpatient environment, you have a lot more latitude as the technician that's performing, the ultrasound or whatever diagnostic test that you're doing. I don't want to answer that question without nursing involvement. I did speak to Dorothy Michaels about it and, get her opinion about it. And she was a little bit more conservative about it. And again, I don't want to. I think, oh, Jesus. That's when you know you're fat. I do it all. When I go into the room, the sinks go on. I'm like, I'm not even near you. My aura is turning things on. So so the thank you. I lost my train of
Involvement,
thought.
policy.
Yeah.
So
So I want to keep Jackie safe, and I want to, I don't want the question to ever be, well, why is Jackie doing it when they're in?
yeah, but we're here and we're
Yeah,
here.
absolutely.
All we need is
So-
just the supplies. Yeah.
Right, just the supplies, and I want to make sure, if it's an ace bandage, taking off an ace bandage, I think that's well within, our
Oh,
scope, but I want to make sure.
Yeah.
Reapplying the ace bandage may be something that we would want a nurse to do. As, things like Coban, which could, quickly turn into a problem for some of these patients because they do have compromised flow. And so putting something on them could constrict them, give them compartment syndrome or so. Nurses over at the Wound Care Center, they go through some serious training, with these Cobans. So, and what degree, because you can put it on at 30 to 40, you can put it on at 60 to 80, depending on how tight you put it on. So these patients have calcified vessels, and they're already compromised. You give them a little squeeze and you close them off a little bit more, you're going to impede flow.
Is there a way to measure it when we put the code down?
Yeah, there is, but to be honest with you, it's an eyeball.
Okay.
It depends on how much you cover when you overlay it. If you layer 25, 75, or 100% over.
Right.
A lot of these patients, with venous stasis, with venous insufficiency, there's three hallmarks. There's compression, elevation, and no sodium diet. We really can't, we try to impress them upon elevation, how that goes. We try to tell them no sodium. I put sodium on my Chinese food, so I really can't. So compression is really where it's at, and that's the one thing that we can control. The other factors, they're modifiers that we don't have complete control over because the patient's with us 1 hour, goes home, and then comes back a week later. And I say, "Oh, you elevating your legs?" It's a rhetorical question because I can tell they're not elevating their legs. So the compression is huge, absolutely huge. And not to say if there's a case that, some of the cases that come on over there, they're pretty horrible. These patients are probably the sickest patients. The wound care patient, who doesn't heal? People who are actively dying, don't have the ability to heal anymore. So they're probably the sickest patients that are living in our community, that are not hospitalized yet because they're not acute, but they are actively in some way, some form dying. So, and their body has lost their ability to heal. We try to help that, mitigate that risk by helping along by doing these interventions, but it is always, so if we are looking for a diagnostic test, we need to be able to ensure that modality continues after the test. And it's not to say, I would love to be able to say that the nurses over there can come over here and give you a hand whenever. The problem is that I am the only one over there that's employed by the health system.
Got it.
So the nurses over there are through a management company. So there's a 10 or 12 nurses over there that are employed through a management company that is contracted through the hospital. So their insurance is not covered. There have been times when people come on over because nurses up on the floors on ICU are having a really tough time with the wound vac. Dorothy's not available, and I'm just like, we have to do what's right for the patient. So, many times, we'll go on over to, the ICU and help them with a wound vac or do something, but, it doesn't mean that, we're over here to help you and then the nurse goes over and takes lunch. You have to be there to be able to assist. And, that's not saying, you're not alone. I don't want to abandon you. This is a collaborative, we're sharing these patients. I want to be able to, but you can't do it unless you have the tools to be able to do it. So I think that's why we're here.
So Hector, would it be best then for my nurses and myself to visit you so that we can be competency on that specific pressure cold bed dressing?
There is no, it is part of the dressing competency that we use. Um, uh, and then I have to look if I have to be perfectly honest with you, I have to look to see if I have a Coban specific competency.
Well, I mean, like an in-service. That's
Yeah.
not necessarily.
So, I mean, to be honest
Yeah.
with you, I mean, I can come on over here with a couple Cobans and we can practice on each other.
Okay.
You know, I mean, and then what's good about that is you get to feel it and
Yeah.
see what the patient's experiencing because that
Okay.
stays on for a week.
Okay. Yeah.
And it's uncomfortable. So, you know, it's uncomfortable. And the patient's too tight, it's too tight. But that's its intention. It's intention to be tight. And we were just having a conversation about this the other day because I see that some of the nurses are a little bit more lax in, the degree of compression that they have to be. It's not therapeutic if it's not being put on correctly. So,
Right.
I had a conversation with the nurses over there about that. But again, when you have the patient in front of you and they're saying it's too tight, you're like, all right, I'll pull back a little bit, but then it's not therapeutic. So then you kind of have to go through the education of we got to put it on correctly. If you can't tolerate it, then we have to think of something else because we can't just be doing this just because it looks good. So how about all the other dressings? I could stock. I spoke to Dorothy Michaels about this, and I could stock. I spoke to Jerry Baldwin about this, and I can certainly get you started, stocked, get it, whatever tool or methodology you're going to use to hold the dressings in, and then we can stock it, and then we can just kind of flow through. When you see it falling down a little bit, Jerry has a stock of pretty much everything that I have over there. I don't know that she has Cobans, to be honest with you.
No, I
I don't think so either, but I can get them for you.
The Coban, we have it,
not
that's
yet.
not
I
the
don't-
right one. We have
Yeah,
the
didn't you
Coban.
see a cart from
You have Coban?
Yeah.
But you have the two.
No. It's a specific Coban
Right,
that does compression.
No,
It's like a
part
white
that, like,
foam
seven
inside or
and-
something.
right. It's a 2-layer compression wrap.
No,
No, not
So-
this other Coban.
Yeah, you're talking about the Coban for the vena puncture or the arterial puncture? Yeah,
Is it
yeah,
good?
that's a little
Where is
different, yeah.
I don't remember.
Kind of the same.
what you're talking
Oh,
about.
okay.
It was on an email.
There was
about
a
the cart,
silver-
and I
we
talked
have
to somebody.
yeah.
That Jerry said,
Yeah.
I have a cart you guys could probably use, and somebody answered, I'll go look.
Yes, I said I would go look at it, but then I talked to somebody about it, and we decided no because I had the
I
cart.
didn't know what it was for.
Oh, I was talking to you about
because
it,
you
right?
have the red one.
I have the red. Oh yeah, because
So
you
if
said
it's
you
for
weren't
that,
sure
you
that
have
I
a-
even had
Maybe
any.
you can fit it, the standard one. I haven't seen it, but I
Sure,
don't
isn't that like filled with RFA supplies?
What?
The red
Yeah,
one?
her red one is filled with RFA supplies. I didn't know that it was for this specifically. I thought she wanted it for RFA supplies. So we have the silver alginate. The honey, do you use often?
Meta honey, yeah.
Man, honey,
there's
I haven't
two-
seen that, but you said Jerry has that.
Yeah, there's two enzymatic debridements that we use.
Okay.
One is the types of different. Oh, you see? Go over here. Does it happen with anybody else? Or is it just me?
Yes.
There are a couple different types of debridement that we use. Whether it be mechanical, it could be, even, cleansing a wound with normal saline is a degree of mechanical debridement. So, the chemical debridements that we use are Meta-Honey, which is old school, circa 1955, and then the newest, of course, is Santyl collagenase. I don't know if you've ever heard of it.
Yes.
So it's and again that's something that the nurses are compensated in because for the wounds that are somewhat dry, there is an enzyme in the collagenase that needs to be moistened. Sometimes the wound has enough exudate where it will activate the enzyme, but a lot of times you have to moisten the dressing that you put on top so that it can activate the enzyme.
You have
so
to
that it
protect the
can
surrounding
continue.
healthy skin, right?
Pardon me?
You have to protect the healthy skin. Or no?
Kind of collagenase, yeah. Usually you don't really want to get it on, but collagenase will not affect the good skin.
Okay, good.
When you use something like silver alginate, that you have to cut the size of the wound because as the wound drains, it will saturate the dressing and it will macerate the peri wound, and that will actually cause the wound to get bigger
Oh Lord.
because you will kill the surrounding peri wound skin. So that that you actually see, because we measure the wounds every time we take pictures,
Got
every
it.
time they
Got
come,
it.
and we'll actually see, when it's not cut to size. So a lot of times, I'll see the patients in the hospital, and nurses on the floor, we'll take, a 4x4 of
And just-
silver alginate and put it right on top of a wound that's really 2x2. and then the wound drains, saturates that primary dressing, and it macerates and waterlogs the peri-wound, and the peri-wound skin dies. So actually, that wound actually gets a lot larger. So, you know, and you know, that's something that we know that we were taught in nursing school, but we forget. You know, we
Yeah,
forget
yeah,
all
yeah,
the
of
time.
course.
So it's worth it's worth revisiting, I think. But I think that's, you know, if we have a cart and we can set up a process, I think, you know, to discover exactly what your limitations are, you know, if any, is, you know, kind of the next step. But I just wanted to know where, you know, where we can go so that we can kind of pull other people into the mix that help us make a decision that's,
I think we gotta get nursing ed,
yeah,
probably.
yeah, I would like to, Deb Friedel was
Deb
kind
Friedel
of my,
is probably a good one to get
yeah.
involved and just.
yeah, get Deb Friedel, she'll, you know, she'll try and kind of put the hammer down and say, this is what you can do, this is what you can't do.
I have one question.
Yeah, so, you know, I'm inclined to say that she's probably gonna say that, you know, it's gonna be limited.
Yeah.
You know, I'm inclined to say, because we were saying, why is she doing, what is the purpose?
Yes.
And the purpose is, well, because to expedite
Yes.
when we have nurses available, or is it the easier decision? Sometimes, you know, the best decision isn't the easiest, you know, we kinda
Correct.
have to reorganize how we
have to do the
approach these
best practice.
patients.
Yeah.
Which is hard, it's not an easy task, because you don't know when they're coming, or,
Well, it's when
they're
they
late.
come and then the scans. I don't know how long a scan takes. It
Right.
depends when I put the probe down what I see. So it could take me a half hour. It could take me an hour and a half, depending on what the patient has pathology wise. If there's no pathology, you're cutting a half hour off the test. If there's pathology that I have to try to figure out, find, follow, document, it takes a lot longer. And then the patients themselves, they have been here for X amount of time. They don't necessarily want to wait because a nurse is in a procedure, which we know is important, but they don't understand that. They want to be wrapped and go, or I can take care of it by myself. They have
Thanks,
the
Jen.
stuff at home. You know, there's always an answer why they want to get out of here when we're done.
I know.
And I do have a question about if the patient has a
Talk to you later.
appointment in wound care directly following the test that I do, what is the protocol for, do I get them involved to rewrap totally for them to take it off in, you know, a half hour, or do I leave them?
If they have a,
I'm asking because they tell me all the time to leave it, and I'm like, well,
what, leave the dressing?
no, like if I unwrap them and I do the exam, and they're saying, well, I'm going right to wound care.
Yeah, I think that it's okay
Yeah?
to just put a dry dressing on and
Okay.
cover,
Okay.
because we're gonna, whatever you do, it's kind of a waste, because
You're on
you're
They're
not
gonna
have,
undo it and
yeah,
it'll
you're not
look
gonna
like-
have any bacteriostatic benefit from having it on for 20 minutes.
Mhm.
You know, as a matter of fact, I think it'll be the opposite, because if you have epithelial growth or, you know, epithelialization of the wound, you know, every time we put on, put off, we're taking that new baby skin with it.
So what's better to put on there then, just like a telfa? If they
Um,
have, if they,
Oh, no,
Yeah,
if
you
they're
can put
draining it,
yeah,
just a
yeah, you can put a
Telfa or-
telfa on. You really don't need the order for the dry dressing,
What it says.
so you can
right?
just kind of put a dry protective
I'm
until,
speaking.
and then they'll come over by us and we'll put the other
No.
dressing on.
No,
yeah.
I'm speaking, but
Sounds good. We have plenty.
Non-sticking, but
Yeah.
that's something that I should still get nursing involved for if they're going right to wound care.
Thank you.
Let's talk to
Yeah.
nursing
Okay.
ed about that. I don't want to answer,
Okay.
you know, on behalf of the hospital for what their
It gets tricky all of a sudden
sorry.
once you involve nursing.
No, I know, and honestly, I'm just trying to do what's
Yeah.
best for everybody. It's the patient, it's my schedule, it's their schedule. You know, they're very busy too. So it's like,
Yeah,
if
yeah.
there's anything that I can take off of
There's-
your plate, I'm more than willing to
I
help
know.
you.
There's no issues with her undressing though, right? She can undress everything, or is even that an issue?
that's an issue too.
Oh.
It's an issue too.
Oh, wow.
Yeah, it's an issue too, because, you know, when we take down the dressing, there's a degree of nursing assessment that needs to be performed. You know, and I was talking to, you know, Dorothy about this. So there is a degree of nursing assessment that needs to be performed. You know, if there's some type of extremis that needs to be addressed immediately, you know, is it really in the best interest of the patient to go through the test or address whatever extremis we see? I mean, and not to be discussing, it's past breakfast time. There's many times that I take off dressings and there's maggots in the wound.
Yeah, yeah.
So, and, sorry.
No, it's all right, I was just wanting to water.
Yeah, so, you know, I really don't want to traumatize you that way, Jackie, but,
Oh, I've seen a lot in a
Yeah,
couple
like-
months that I've been
well,
doing.
you're stronger
Not
than me.
maggots.
Yeah.
Well, I've seen it once.
You're
Not
stronger
maggots.
than I am, because I scream and run out of the room.
Yeah. We've seen them in trachs.
So, what's that?
We've seen them in trachs.
Now that's gross.
I've seen so many
Yeah, I
names.
see you.
Never heard of that one.
I
Oh,
never heard of that either.
Yep.
That's not gross.
that's
In all my years
horrific.
now.
That's horrific.
How well versed are the patients on knowing yes and no? Like, don't touch that or touch that. You know what I mean? Because some of them are like, will tell you, oh yeah, do that. Like, and I know it's a slippery slope, right? Because I don't know.
Right. You know, I mean, there's a lot of
So-
compromise there.
Is it a question or a way to field that with scheduling? Like, you know what I mean? When Melissa's scheduling and she's scheduling the patient, like, do you have a dressing? Are you able to take the dressing off, or can we assist you with it? Do you need assistance with it? Like, do you think that's something we should know when we're planning?
Like, do the patients know well
You know
enough
what I
what they need, or are they gonna tell Melissa, no, I got this,
Yeah.
and then they're gonna come here and it's something that we should really be addressing with nursing? Because I feel like they just
I don't
kind of
think we
say.
can. I don't think we can take the patient's word for it.
I agree.
It
Can
requires-
you-
Yeah.
Is it a way to, like, if there's some really major critical ones, is there a way to flag it when you're ordering?
Well,
Is that, I mean, I'm just throwing things out there.
What the patient is receiving is in the chart. Now, I don't know exactly who has access to the chart.
Is
So,
that in
on all scripts,
all
right. So I know Melissa has access to it.
I do too as well now.
Oh, you do? Okay, so I could actually show you what's in the patient, what the order is on the patient.
Would I be
And-
able to follow you one day
Sure,
for a
of
few
course.
hours, whatever, in wound care?
I'd be honored.
to see what your world is like?
Yeah, not that exciting.
It's different than my world, so it's
Not that exciting.
maybe a few hours just to like
Sure.
see what your end is.
I can
like.
get her access to Jackie all scripts. You know,
Yeah.
access to look that up.
Yeah, I don't
too.
think they're doing the on-site training now. I think it's all,
Yeah.
you know.
But it's not too hard to.
Yeah, no, it's not. It's
To
really
look it
not.
up and then just show her exactly where to go, and then she has a better understanding.
Right. So how many are you scheduling a day?
It's roughly about 3 outpatients a day right now.
Are they mostly wound care?
They're all wound care.
Oh, geez.
And then if they're not wound care, they're admitted wound care in the hospital. So it's
Yeah,
a
that's
lot
true,
of them
that's
wound
true,
care.
yeah.
It's I don't know. I'm just a lot of them. What I notice is they come with like they have an ACE wrap and then they'll have like some kind of gauze with like the medication on the wound itself. What I have been doing is leaving the wound. I don't expose the wound because I'm not gonna scan over the wound anyway.
Yeah.
Like if I'm looking for something that either Dr. DeMarco can treat or something, it's feeding the wound in places that I would be able to see without scanning on top of the wound itself. So for me, what I've been doing, I would say with 90% of the patients is I unwrap the dressing that they have, but I'm leaving the wound covered. I'm not exposing it. And then if anything, I'm just rewrapping an East bandage or the Carlex around whatever. I have seen the compression wraps that you're talking about, and that's usually when I'll be like, Jalissa, this is something
Because
that's
remember we
way
had
more
the
than
situation and we just didn't have it.
that
right,
guy.
and
Right, but that guy was really atypical for what we've been seeing. That was the first
Oh.
one that really came with like all that compression and everything else. A lot of them have like the East wraps with like either the honey or like the and I don't take that off for the most part.
How far out do we schedule the vascular consults?
You'd have to ask for Melissa. I'm not sure.
Yeah. What I'm thinking, to be honest with you, Corey, is how can we help mitigate so the transition is easy for your team and a little bit more clear to Jackie, because everybody seems like we're going into this blindly. Is there a way, and I don't know yet, but I'd like to think about it. Is there a way that we can say, okay, this is the schedule for the week for Jackie. Can I print out all the orders for the patients that are coming so that we know, when Melissa gets what she's getting, the issue is she may be booking out a couple weeks
Yeah,
and
she
the orders may change. So I think, that week, that Friday, for that Monday, Tuesday, Wednesday, Thursday, Friday, can we get a list of knowing of who's coming, and that way I can have someone, one of the support staff, maybe print out the orders. So, I'm not saying that it's, black and white, but it's a better guide as to give, your team an idea of what needs to be done, if anything needs to be done at all, and be able to have those supplies available to you when that patient comes. So that might be, a mitigating effort that we can use, to help this situation. I think we
What
can
if we do like a SharePoint calendar that you guys can check into also?
He would know. Yeah, it's pretty cool.
You know, Jill just mentioned something like that.
Yeah.
About something
It looks
else.
like that.
I think I gave you
Yeah.
access, but I haven't shown it to you yet.
So you can see what we have on the
I
schedule.
can't see that.
So that's what we had today was an angiogram.
But you can make it look different, and then you can just double click on it and tell you everything about it.
Okay.
Yeah.
Okay, so I get it. So just like if you were to, you mean like if you were to enter
That
what the
we
patient
would
was coming
enter
here for,
everything.
and
We would
then I
have
would say what
Melissa
the
book
patient
it,
has.
enter it, and then you guys can see it real time of what we have. So even if you want to do it the night before to create a little tackle box to bring us the next day to what patients that we have.
And you could
Yeah, I
even
don't
write on
know.
there, hey, honeycomb, whatever, and then we would be
Yeah.
able to see that
Right.
too.
I think it would be best if you had the supplies here available
Yeah.
to you.
Yeah.
Yeah.
Just has a heads up as to what's, what patient A is. Maybe they have a dry dressing. You don't have to worry about it. Maybe we're just putting something protective, but
Yeah, because at this point we just have the silver alginate, but we don't have anything else. I don't
Yeah.
have the Meta Honey. I don't know if you have that, but I don't have the Meta Honey or whatever else.
Yeah. So you
The
kinda,
Santil.
the collagenase.
Yeah.
Yeah. So you kind of need a little bit of like a mini.
Yeah.
Almost a little mini wound care center to be able to be, because you're treating wound care patients.
Yeah.
So you have to, it's a poor setup right now. So we have to improve upon it. We have to do better for the patients. We need to streamline it, keep Jackie safe, keep her moving. The idea here is, sorry Jackie, is to, a vascular lab is standard of care in wound care. I've worked many, many years to, get a Dr. DeMarco here, and they were Dr. DeMarco's before Dr. DeMarco, but they weren't Dr. DeMarco. But now we have someone who is aggressive in their approach and revascularization, which is, so important in wound care. Patients can't heal unless they have vascularity. They're optimally vascularized. Sad to say that there are wound care centers out there that don't meet this standard of care, and they're treating these patients. I see them come to me all the time. They've been going to wound care for 4 years. I'm like, of course, because you would never optimally vascularize. So, the idea is to be able to, provide this standard of care for every patient. And I think we saw in the last couple of months the jump, because I changed the algorithm for new evaluations. There's not too much I can do for existing patients, but I changed the algorithm for new patients. So, the first visit is strictly an assessment. We're going to do our punch biopsies. We're going to do our cultures. We're going to do everything that we can to prep. And then I've worked with Dr. DeMarco on exactly what type of test that we need for visit number 2. So for visit number 2, and visit number 2, includes a vascular consultation. We may or may not have the test that you performed yet, but we don't want to hold up care because of those tests.
But it's also helped, like, with us, me and Corey worked on recreating, like, that,
No, go ahead.
that order form.
I'm good.
Okay.
And even, like,
Thank you.
I know Dr. DeMarco has to approve the arterial Dopplers being done. That saves a lot of time.
Yes.
If a patient comes for an
so
ABI,
long.
you're talking 45 minutes. If they
It
come
was-
for an ABI and a Doppler, now it's 2 hours that they're
It
with
was
me.
incredibly sloppy.
It was
And
crazy.
it was incredibly sloppy because you had doctors, and no disrespect, but doctors whose specialty is not vascular surgery, just punching
Putting
a couple
everything.
lines on the computer to order something, and it wasn't appropriate. And it is much better now. Dr. DeMarco, they kind of know what they're supposed to be doing. They're very limited as to what they, kind of put the kibosh on them and said, this is what I want you to order and nothing more.
Well, we're really starting from the ground up. I mean, we're starting from, I took over the lab a couple months ago. I'm doing things differently than the previous techs did. I'm doing a lot more than they were doing, so it's a lot more time consuming. So when the doctors on your end are putting in 3 tests, I'm with them for 3 hours almost,
Yeah.
because I'm taking double the amount of pictures and documenting a lot more.
Yeah, and I think that, credit to what you've done, which I've heard nothing but amazing things about.
Thank you.
And I want to keep that momentum. I want to
Yeah.
be able to support you in the way that you can support our patients.
No, and I
'Cause,
appreciate it.
They're our patients, really. They're not my patients.
Mm-hmm.
They may start over by me, but they work their way over here somewhere or another. Somehow or another, all these patients get to be seen by us. Even our PIC friends,
Yeah.
my friends. Oh I got a mouthful yesterday.
There's just wound care is definitely a specialty in itself, and it's a whole new. You know, I've worked with radiologists for the past 12 years, and now it's like working with vascular surgeons and like seeing how much more in depth these tests are. I love it. I like it, but I'm a one tech show here, so it's very hard when the patients come whenever they want, and then I'm with them for an hour, and then it's like if I'm not doing anything, I'm not gonna turn them away. You know what I mean?
No,
like if they
absolutely.
come an hour late and their wound, I understand it took a lot to get here. I'm not gonna be like I can't take you,
Yeah,
so
with
I'm
these-
gonna see them.
With these patients, many of them
It's
have
just-
one leg, they're struggling to keep the next leg, and it's hard. And,
Yeah.
you know, over there, I'm seeing about 75 of them a day.
Mhm.
And, you know, I only have 6 exam rooms, so it's a struggle. And they're like, oh, I couldn't get here. My prosthetic wasn't clicking.
Yeah.
You know?
And
You're
honestly,
gonna-
we've done a lot in
What are you
4
gonna tell them?
months.
No? So, yeah.
We've
so,
done a lot
yeah.
between the ordering. We've cut down on a lot of like the unnecessary tests. If they have an abnormal EBI, now let's get a Doppler.
Yeah.
You know, we're not gonna do just everything together. It's
Right,
like,
right.
or is their wound an arterial wound or is it a venous wound? That's 100%. You know, it's different.
I think that, you know, the vascular lab has come a very long way. We're doing things a lot differently, a lot better. But I still think that, you know, together we have a lot more work to do, you know, and, you know, I can absolutely help support, you know, Melissa and your team, which is phenomenal, you know, in every sense, you know, because we share patients with PICC insertions, we share patients with wound care. You know, Jackie you are such an important cog in this healing process with these patients. So if we can, you know, work together, and this is where it's at in healthcare today, these multidisciplinary meetings,
Yes,
you know, we
it's
have
all about collaboration.
3, 4 different departments sitting here right now talking about how we're gonna care for these patients best. This is the kind of stuff that brings tears to my eyes.
I know.
Because
I
this-
agree.
This is nursing.
I know.
You know, this is the essence of
beautiful.
what we do to help patients, and I love it. And you know, we can do more.
Yeah.
We can do better. Patients deserve it. So let's, you know, let me reach out to Deb Friedel. Let's loop her in to see exactly what you can and cannot do. Let's secure that cart. Let's stock you with goodies. You know, and then let's also talk about what is it called? SharePoint.
Yes.
That's the calendar.
Yeah.
SharePoint. I may be able to have.
We could easily I could talk to Melissa. She could easily send you guys the schedule, but if there's a miscommunication or anything, SharePoint's just a lot. I feel like you guys have really, it's been super useful where everyone real time can see what patients are
Right.
here rescheduling, so you don't need it Friday for Monday, Tuesday, Wednesday. You could do it Monday for Tuesday, Tuesday for Wednesday, and just kind of see real time
My
what's
only
going on.
concern, my only concern with the SharePoint is that it's not an actual order; it's a reference,
Yeah.
and that's so. I
Right.
think we
And
still
sometimes
need
it's
There's
not
to.
there's
updated
that
all the
human
time.
error in
Yeah,
entering.
I still
Yes.
would like to, because more than likely, I think that's okay. It's okay for that to be a clerical duty.
Yeah.
You know, and I can find someone. You know, anyone can look and say, okay, what is it? And, you know, they can type in the orders in the SharePoint. But I just want to make sure, from the nursing point of view, that we're looking at something that is in order.
Yes.
Gotcha, okay.
100%.
The
I
other
didn't
thing is,
take-
like, respectfully, like, and I mean this in the best way, I love her. Melissa's not clinical like we are.
Right.
So when Hector looks at something, or I look at something, or you look at something, it's a whole different thing.
Different scope. The way
You know,
you're
like
looking.
she's still kind of trying to figure out what the difference between venous insufficiency and an EBI is.
Yeah.
That's not her scope. Like,
Yeah.
for me to tell her it's an artery or a vein or whatever. So, like, to rely on what they need from what she's scheduling, I'm not sure that that's fair to her. She's doing a great job. I
Yeah.
just think that it's not her realm to say, you know, exactly what the patients need.
I also think like
100%.
the realm
I
of
agree
how
with
You know what I mean?
IR
And I mean that in the best way.
Absolutely.
I don't mean that in a negative
I
way at all.
totally agree.
the way that the IR is running, I feel like I'm gonna announce that I did hire somebody, which is starting in May. I think that nursing will be able to hopefully support you and the service a little bit better
Yeah.
moving forward, because I think I have to rethink about how we all structure ourselves here in IR, because we have, you know, Definity and then wound care. So I think we're gonna be doing great things.
And I think also, you know, I am not above coming here and helping your team. You know, if you are in procedures and, you know, you want to break sterility, you don't want, I mean, nobody wants you to do that for dressing change. And I know that these patients, their time is valuable and they want to go home. You know, if you're like, Hector, I'm anticipating on this coming out, you know, Hector, I'm anticipating on this patient coming out in half an hour. I have nobody. You know, let me know.
Yeah.
You know, I think that it's
I think that's something that I'm struggling with is like the timing because I
Yeah.
really don't know and I
Right.
don't have that extra person to be like, hey, can you call,
Right. I
you know,
mean-
like whatever during a scan. Like I'm kind of just going as I go and what I see is what I see and like I can't tell you how long I need. I don't know. That's the amazing thing about ultrasound is it's 100% not straightforward.
Yeah.
You know, like a CAT scan will be like this is the time frame. Ultrasound is not like that.
Right.
And like I said, I was a general tech for a long time and the scans were more predictable. This is a lot more.
And I think that, you know, and to Jackie's point, the unpredictability of what she's doing, we can't have, and you know, and I'm coming to realize myself, to be honest with you, that we can't have an exact plan.
No.
I
We need
know.
to have flexibility.
That's
So-
what I mean with us, more
Yeah,
flexibility.
but flexibility. So you know, between your team and me, and you know, I'm not at Syosset too often, but I'm trying not to be at Syosset too often. But you know, if that runs into a problem, you know, call me over. You know, I'm still a nurse, so I can come on over and I can do the dressing for.
And I think we can do a lot of things on like the hospital and not to cut you off. I just feel like a lot of things on the hospital, and, like me moving downstairs or being closer to you guys in proximity.
That is
It is
amazing.
so
Yeah.
important because I can call them quicker than saying, "Hey, I'm all the way across the, you know, come out of
Yeah.
your
Yeah.
procedure to help me all the way over there."
Yeah.
And it's like, you know, you might have time to help me if I'm down here,
Yeah.
you know, and it's a huge thing where
I didn't
you're.
even know you moved.
Well, my
I was
hallway is
I
closed.
was telling patients. Yeah, I didn't know. I told
I'm
patients-
renting a space in
I was
Ulsan.
telling patients to come on over to where they, you know.
Upstairs?
Yeah.
They'll be met with a wall.
Yeah.
They won't be able to get past. But
So,
they're doing cath lab construction, but you know we're in the talking processes of trying to make me closer,
Yeah.
and we're in the talking stages of trying to figure something out. Because if I'm closer to IRD, it might help them if they're in procedures,
100%.
you know, to come down here instead of upstairs and across the hospital, which will be better for the patients and it's better for me if
We
I
saw
can't
it
tell you
already
how
with
long
the
I
first
need
2 RFAs, how wonderful that was.
because I'm closer.
Yeah.
so I think we
So-
made a lot of progress today. I
Yes.
think we, you know, a better understanding. This is so important to, you know, meet with everybody and, you know, have a better understanding so I can support your nurses, support you, support Jackie, support,
Everything.
I don't know, the Irish Leprechaun, everybody, anybody who has a stake in this. You know, there's many stakeholders for one patient.
I know.
Many stakeholders. So I think that, you know, as much support and, you know, I can, now that we have an idea, we can gather a little bit
Diana.
more and move forward.
Good.
You know, I'm going to bring Jerry into the loop, that make sure that she has a
Absolutely
fresh supply for your team.
Oh.
Let me come on over and start
Wait.
the cart the first
No,
time
I'm
for
in.
you,
I'm in.
so that we
Perfect.
can,
I'm in
let's
IR.
get your team up and running on Coban
No.
compressions and anything that they may feel, that you guys may feel
Oh
uncomfortable
no,
with
I'm not there.
or unsure about.
No.
Bring me into the loop if
I'll come-
you have
I'll
any
come
problems with
pop
the
in
patient.
on the way out.
I don't want you to have to,
Okay, bye.
you know, patient B to have to wait because patient A doesn't have a nurse to put on a dressing. I suffer from that same thing myself over in the chamber room when there's no nurse available and the patient is waiting to go into the hyperbaric chamber, and those patients are in the chambers for a couple hours at a time, and the patient's sitting there and I can't move that patient off that stretcher because there's nobody to change the dressing. All the rooms and every nurse. So I understand your problem absolutely. The difference is you can't break sterility to go just take care
Well,
of that patient.
we are not we are not circulating with the surgeon sterilely.
Oh, I see.
We wear our
You're
lead and
clean?
we circulate, but not in a sterile fashion.
yeah.
The techs do.
Okay, so I usually, right. So like when I do split thickness skin
Yeah.
grafts, with,
She's sterile.
yeah.
We're not.
Yeah. Normally when I do split thickness skin grafts with her, you know, I'll have one sterile nurse, and I'll always be the dirty nurse, you know, so the clean nurse. So we kind of run similar setups, you know, just different.
Yeah.
We'll talk about the SharePoint.
Yeah,
I think that's
I
great.
didn't get the nursing aspect of it, which is the whole aspect of it. So, whether it's Melissa sending you a schedule or anything,
Yeah, just
it'll be
if
fine.
Melissa sends me a schedule, let's say for the week.
Yeah.
Then what I can do is either A, there's two options. Either we can do SharePoint, or B, I can print out those orders and then send them on over, you know, in
Yeah.
an email form to let you know what exactly is needed for those patients. So,
And also,
Yeah.
if we can ask Melissa just to be more specific on the SharePoint. If she doesn't know what
Yes,
tests
ma'am.
they're getting,
When the patient
let her
for
put the
MRI with
CPT
the
code
wound,
down
you
next
know.
to
So did you tell
what
the
it is, and I'll give
patient
Hector the
what
CPT
type
code.
of dressing you're putting on?
Well, the problem is that this
So
is
we
the
know what they're
problem that
coming
we
for,
have is that
exactly.
the
Yeah.
patient there's an optimal dressing for the patient that the physician will order. The MRI could be scheduled 2 or 3 weeks in advance. So, and we don't necessarily know when the patient is coming for the MRI, so the patient unsuspectingly may come here with a silver infused dressing. So, and your team, the team upstairs is great at realizing this, but, if I know a patient is coming, for a test on Tuesday, I'll tell the nurse, don't put on the Coban, and it's Monday. Don't put on the Coban because they're going for the test tomorrow. Let's just put on an ace
Yeah, because
bandage
that's
today.
what happened. That's such a waste on that poor patient.
Exactly. So, unfortunately, we don't always know when the patients are
I
coming.
know.
I was gonna say that's the
Yeah.
other thing is that sometimes I do have patients they come right for wound care for a test and it's like now I'm just undoing everything that you guys did.
Yeah, we don't know that they're coming.
Yeah.
We have
Yeah.
no idea that they're coming.
If there's a way
You
that
know.
we could solve that, we would take care of a lot of.
Right, so I think that we
That
have
too.
to. I think the SharePoint
Yeah.
is a great idea, and I think it may help us. I don't know that it will solve the problem, but I think it will help us.
Okay.
So I think we'll have a little
We'll-
bit of homework.
we'll
to do,
collaborate with that, yeah.
I think the benefit from a little bit of work from each of us is going to really impact the service, and lead us to better care, better, more optimal outcomes, increased volume. Sorry, but I know you're up for it. So, and then make you guys feel comfortable when you take care. I don't, I would feel uncomfortable too if I were you guys. So,
Yeah.
absolutely, I want to be able to support everyone.
Because you
as
guys are the
best I can.
specialists, and we've done it, but we've done it in the years of, so things have changed.
Hi.
See you later.
All right, I'll talk to you
Bye,
later.
Marco.
Like that important thing about cutting the silver alginate to the size of the wound, because it's all part of continuing education, because maybe some of us didn't see that one before.
Yeah. I think when we
Remember
went to nursing
Dakins
school.
back in the,
Dakins, yeah.
Yeah,
so
I
like
was.
everything has continued to,
I've never, I wasn't a nurse my whole life. I was a New York City fireman for, I retired from the New York City Fire Department. But back when I went into the fire department years ago, you can get in when you're 18. Now you have to be 21. You have to have like 40 credits. You have to 25 years instead of 20. And
What about sugar in my lantern?
Oh.
Remember those?
what's that?
Sugar in my lantern
No,
and a heat lamp.
really?
oh no,
Yeah, you
Nah,
would take, you would
you're
take them
dating
over to
yourself
the
now.
side. Yeah, but you would put sugar, and then you would take my lantern, and you would put my lantern all over, and you would lay them on their side, literally tape them over to the bed rail, and then you put a heat lamp on them.
that's crazy.
That's a long time ago.
What?
It's almost 40 years ago.
Never heard that in
And
my
then,
life.
and then honey came along.
Yep,
Wow.
yep.
Wow.
Sugar and my lantern was a big thing back then.
Ugh. That's why they got maggots.
No kidding. I mean, I remember how long we used to do the heat lamp treatments, but you would have to sit there with the patient so they
All
wouldn't
right.
get burned with the
So we'll find a little card, we'll get the goodies, and then the next phase would be for us to, like you said, maybe carve an hour or so that we can play with each other with the Coban
Yeah.
thing and get a feel for it.
Yeah, definitely. And I have a, once I show you one, to be like,
Yeah.
I got it.
Yeah.
Because it's really, I've been teaching people how to put on Cobans for 10, 12 years now, and nurses that come over there. Some nurses come on over with no experience.
Yeah.
But with with a willingness to learn. And
Yeah.
I think that's more important than the
Yeah.
knowledge
Yeah.
itself, because you can come with preconceived ideas of how it should be when it might not
Not.
necessarily be the right way. So, I put new nurses. I put them in double Cobans. I'm like, how do you feel? They're like, tight. But it's gives you the patient perspective, and
Yeah.
you get to see it's not something a patient can do on their own. So it's something that we definitely have to help them with.
Now, when we put them on, how long are they in these things for?
A week.
A week,
A full week.
a full week.
Every patient who are coming in the wound center.
No, they don't all have the COVID.
not
They don't.
all.
Oh, right.
No,
Yeah,
some
I
of them
would
have
say-
ACE wraps.
Right. Sometimes we'll put them in ACE wraps because we don't want to put them in Cobans until we get Jackie's report. Because if they are vascularly compromised and we compress them and we can compress those vessels, So most of the patients will not have a Coban because we are afraid that, you know, we're sending them to you to determine whether
They
or
want
not
to
we
put
can.
compression for the veins,
Yeah.
right? But if the arterial system is
Right.
calcified, and now you're putting pressure on that, now they're not going to get flow to their feet.
You're right.
So they have to check kind of what mine comes back to see how they could treat. So it is all connected.
yeah.
Yeah.
It's just it's a lot of them are ace wrapped mostly,
Most of them because their legs are gigantic.
and they're weeping and they're
yeah, so we have to do something to control. But you know, ACE wraps. You know, even if you look at all the guidelines and all the evidence-based medicine, you know, ACE wraps are when you know sprain your ankle.
Yeah.
None of these people are doing calisthenics at home.
Yeah.
So it's you know they need therapeutic, heavy-duty compression. You know, I mean, there are some doctors that want to use 80 compression. I said, you can't cut off arterial flow. Some of these patients' blood pressures are only 80 by 50. You know, like, I said, no. They want to go up to the thigh.
Do
And
they
the
have the
patient-
compression machines? Like,
They're lymphedema pumps, but they are, you know, what I do is, you know, we used to be involved with, but it is a problem because, you know, patients have, you know, a lot of these patients have a lot of comorbid factors where, like, you know, they're congestive heart failure, then you have to get them cleared through cardiology first. Before we do lymphedema pumps, then you have to be responsible for the pressure, how many times a day. So most of the time, and we really can't, you know, the companies, the vendors say, yeah, well, it'll help the patient heal the wound. But then the wound drains inside the lymphedema pumps and it's disgusting. And they don't wash them. So I'd like to artificially control the conditions of the patient, get them healed, and then send them to a lymphedema clinic. And I use STARS in East Meadow and STARS in South Shore University for the Suffolk patients, and the one in East Meadow for the Nassau County patients. So I have a good relationship with them, and they take our patients. So, but yes, absolutely. I mean, lymphedema is huge. Some of these patients, I was just walking here, and I was, you know, walking past the unit, and I mean, literally, I mean, there are patients with ankles the size of my thighs, and I am not small. So, I mean, it's very sad. And you know, these legs can weigh 100 pounds.
Yeah.
They're very, very sick. And that's
Yeah.
why, like, even, oh, Dan, it's hard enough for me, that, like, it's hard to do this by yourself. To move these patients by myself, it's a lot. They're not able to stand. They're all in wheelchairs. I have to get them onto the bed. It's a lot.
To hold up
You have
a
no
leg
one else
to
to
wrap
help
it.
you, like?
I mean, if I'm in ultrasound, yeah, but, like, upstairs all by myself,
No,
well,
yeah,
you
you're
know
by
what I mean?
yourself.
Like right now, yeah, I'm training people, and, like, there's a second person, but right now it's a one-touch shop.
Somebody, right?
Yeah, right.
Yeah, we have to, I mean, I think it's gonna grow in time.
Wishful thinking.
I think we have a lot of people. I
Once
mean,
we-
the wound care population itself, outpatient wise, is a lot on the schedule, and then you're talking inpatients, and you
Yeah.
know.
I think that, you know, once we start, you know, we have a lot of work to do. We're gonna start chipping away at this, and we're gonna get better every day, every week.
Where was
you know,
it?
maybe not every day. We won't see that, but every
Oh.
week we're gonna get a little bit better.
Telly.
And you know, then we're really gonna have a product to be able to present to Dr. DeMarco, administration, and say, listen, you know,
Right.
we've kind of taken this, you know, and this is really a great PI
Right?
that I
It
would
is.
like to
Yes.
incorporate, you know, nursing in as a whole.
Yes.
You know, one for Magnet
Yes.
and two for the Joint Commission when they come.
You got us.
You know, I think that that's great. I think, you know, we can really showcase your
Yes.
programs. 'Cause-
Yes.
And Jeannie is,
I know.
she sets me straight. Jeannie's like,
I love my jeans.
send the patient for a PCR on Friday. I'm like, yes, ma'am. You notice I ask you when you want me to. So I'm like, when do you want me to send them for a PCR? She's like, Friday. I'm like, perfect.
Perfect, we'll do.
So, are we all good?
Thank you
I think so,
thank you.
Oh, it was my
Perfect.
pleasure.
much.
Yeah,
Yeah.
it was my pleasure.
So,
you know.
so much.
You know, just I'm not gonna come here and tell you how to rap. You all know how to do that, but you know, the things that you want, you know, a little assistance with, that would be shown. Then I'm happy to, and then you know, we'll take it from there. So, I mean,
I do have
let's
one
just-
question before you go. Should I be touching anything right now or no?
He's gonna talk to
I-
you.
Let me talk
Because
to-
I have patients today. Like,
I know.
is this something I should be bothering them for everything, or
For
should
right
I?
now,
For right now, please
unfortunately,
do.
Yeah.
Yes,
That's
call
the
you
nature
for
of the
everything?
beast.
I'm-
Do what's right.
Only because I want to keep. Most importantly, you know,
Jackie, don't
you're
feel
not
bad.
going to harm
Do what's
anybody.
right. We're
Yeah.
here.
You're not going to harm any of these patients. You can't do anything really wrong to hurt them. My biggest concern is you, and keeping you in a safe place that you are not questioned for doing something that
Yeah,
you may not.
jeopardize
So if it's just an
anything.
ACE wrap, I'm still calling them to
For
remove
now,
it?
I would.
Okay.
Yeah. An ACE wrap, I don't think you can. I think you can remove an ACE wrap. Putting it back on, I think. Do
Okay,
you
so I
guys
can
agree?
do the test and then I can
Yeah.
call
You
you
guys
before they
agree?
leave.
Yeah.
Okay.
Yeah. Yeah. I think taking it off is. I allow the text by me to take off the ACE wrap because you're really not assessing a wound because there's a dressing underneath the ACE.
Right.
So, but the primary dressing, yes, and applying it so that we know that we're applying correct.
It's just more communication about what you have scheduled, that's all.
Okay.
Yeah.
And then we can plan.
Well, as long as I can start the test and do the test, and then I could just call you guys once instead of twice per
Yeah.
patient, I think it would be better.
So one of those
Okay.
puffs, nice. I would totally rock those.
Right? They're nice.
It was a puff day.
Yeah. I just want to have some time frames. So I think I'll reach out by the end of tomorrow. I would hopefully have reached out to Debbie and
Dorothy or
Dorothy.
Baldwin?
and Jerry and talk to them about the product, set something up with them.
Yes, please.
For the SharePoint,
Yeah,
middle next week.
easy.
Okay, perfect. The scheduling with Melissa or Corey and Jill are in here. But I'll touch base with them and see how she can, let's develop a process, see how we can share the schedule so you guys are best informed and
Yes,
have a
please, yeah.
guide.
I'm also gonna have Melissa put the remember the CPT codes that I was
Yes.
talking about? I'm gonna have her, instead of interpreting what test they need because the indications are all very similar, I'm gonna have her put the code on and I'll give you what the codes mean
Okay,
to us.
yeah.
So like if I look at the code and I see a code, I know exactly what test I'm doing for the billing purposes. So
Right.
I'll give them to you so you can look at the calendar and you can know what they're coming for.
Yeah, CPT confuses me. ICD-10 I got down.
We use the same three with you guys all the time.
Yeah,
It's
yeah.
not bad. It's just I'll tell you if they end in a certain number, that just means what test I'm doing.
Okay.
So if you wanna, I'll give it to you now actually before you leave. I'll write it down.
I'm not that smart.
I'll give it to you. It just makes it easier because then Melissa doesn't have to interpret what we're doing. You know, whether it's arteries or veins, it's really just put the code down on the
Yeah.
script, and then we can figure it out from there.
All right, perfect.
Good.
Wonderful.
All right.
Thank you
Very
so
simple.
much.
Sounds good.
Thing
Thank
hasn't
you,
gone off
everyone.
behind me. I've been thinking about it for the last 20 minutes.
You did good, Hector.
All right.
All right, ladies. Thank you so much.
I'll send you